next patient is a patient of mine whereby it is an Asian patient that you will see. And as you can see with Asians, as we discussed, a lot of them are concerned about the nasal shape of the flatness and the flat bridge in the tip of their nose. So this is a before, this is her after. So let's start with Dr. Kassir.
So the dorsum and the tip look projected. So from the base view, she's more triangular and a little bit more aesthetic. And she has more of a bridge. So it kind of takes care of that flattened look from the front and the side. So it's nice job, nice aesthetic result.
What would you do?
What would I do?
Surgically versus non-surgically.
Well, since this is a non-surgical talk, I would do non-surgical on her. I would essentially do what you did. I would build her bridge, her nasal tip, and her nasolabial angle with HAs.
With HAs. You would not use radius or Bellafill or any of those, right?
Categorically not.
Yeah. Okay. Dr. Buford?
Same thing. I would use HAs. The biggest fear that I have is some type of a embolic event or occlusion. So I'm going to want something that I can easily break down if and when that becomes a reality. And I would do the same thing. But I mean, nice job. I mean, I think the non-surgical rhinoplasty is becoming more popular. I urge anyone performing it though, understand the anatomy before doing it. It is so important to know where to inject, and also as well too, which product to inject.
Absolutely. Shino?
Yes, I don't do tons of non-surgical rhinoplasty. Do I do it? Yes. I have to be honest, this is an area that really keeps me up at night whenever I do it. I tell my patients, I don't care if it's 3 in the morning, you have discomfort, please call the service and I will meet you here. And that's something that sometimes you don't want to tell your patient. And I do it, especially when somebody already have a rhinoplasty, because as I take a cadaver course every 2 years and I always get humbled by what I see. I take precautions when I do it. Avoid high velocity when working on this area, large volumes. Always check your work, count to 6 to 10 seconds to make sure that you know intravascular. There's a lot of different ways how the facial artery can cross the nose and a lot of variations. So just because never think that's not going to happen to you, be prepared, to act promptly when something happened to you. So I tend to decline any patient that already have a rhinoplasty. I would send it to a plastic surgeons that do non-surgical rhinoplasty because I like to sleep well at night. So if you decide to do this, make sure that you know anatomy and you know if there's a complication, how to treat the complication.
I absolutely agree, and that's something I always share with everybody when I'm teaching any classes at the program.
A beautiful result. Congratulations. But obviously what I'm noticing is that she has hypotrichosis of the eyelashes. Her lashes are very short and thin and maybe even sparse. You can barely even see them in the before and after photos. So if she has some lashes there, maybe we could use a little bit of Latisse, Omatoprost, or the Eyelash type of product. But very often Asian patients come to see me because they have very low density lashes or lashes that are growing very short. And so eyelash transplantation is very popular in the Asian population. Eyelashes grow permanently in the lid once transplanted, and eyelash transplantation comes with scissors because she has to continue to trim them probably each month, that's maybe twice a month or so, and curl, perhaps even perm them depending on her curl and caliber of the hair in the back of the scalp that we use.
Interesting. That's good to know. Thank you. Dr. Tsai?
So having such a high number of Asian clients, they always ask for non-surgical rhinoplasty because I'm not a surgeon. And the typical comments I get from them is, I have a pug nose, my tip looks like a doorknob. And basically they want their bridge elevated because typically Asians, we don't have a bridge, so they want to look more westernized. And so you got to be careful. And again, I do take cadaver courses at least yearly just to familiarize with the anatomy. And so you got to be careful. I do turn away if they have prior rhinoplasties. I know that it changes the anatomy. They're not happy about it, but I've done it a few times. But I try to stay away from those high-risk cases. And I usually don't take a nose case before coming to an Empire teaching event the next day, because and I have them send me a picture right afterwards. But using HAs, I like either something with high G prime. Voluma Restylane Lift has a higher G prime. I used to use a lot of Radius. I don't anymore just because of apparently you can't dissolve it, but you actually can. And just regarding the tip, I use a technique where I learned in Asia, they use a cannula and they go from the tip with a 22 gauge cannula straight down the spine, and they draw retrograde up and lift, and they've done like thousands of these. So very nice work, whatever you did.
So I actually did not use any HA on this patient. I did not use any filler. This patient was treated completely with PDO threads and Botox as a neuromodulator. The neuromodulator was placed in order to lift the tip along with the PDO threads, depending on which type of threads, because there are certain types of threads that you can use for that. Not every company also makes it, but what it does, it goes in as a hook to anchor and lift up and define the bridge of the nose, and the patient was very happy. Now, what I did share with the patient, because as you can see, the definition of the bridge is nice, but if she needs more projection at that point, then I would bring her back, and then I would go ahead and add the fillers to it if she decided that she wanted to do that. And as well as with your approaches, what you just mentioned is how to build the tip, she can get that. But I think from, as you can see, her tip is very well defined there, but it's up to what the patient, how much more she needs.
Beautiful, beautiful work.
Thank you.
Which thread is it? PLLA thread
PDO.
or PCO?
PDO.
PDO.
PDO. Well, it's just the polydioxanone, not the PLA. You could use the PLA, but I tend to use the PDO because also, I mean, you get as good of a result. The PLA, of course, is much longer longevity. And then, of course, if you were to use the permanent threads, in patients like this, and this is something I say to patients, even with HAs for fillers for the facial contour, I always give my patients the option, especially if they're newbies in the world of aesthetics. If they want something that they don't know if they're going to like or not, then the HAs are all dissolvable. So I'll be like, let's put this in, let's see how you like it, let's contour and see, and if you don't like it, then we can always dissolve it, take it out, and we can modify it. Once I get accustomed to them, they get accustomed to me, and they want something more longer lasting, more permanent. At that point, I also know what they like. Then I will go ahead and add anything that's more long lasting for them as well.
About how many? 6 to 8 on the bridge?
For what, threads?
For your threads. How many single threads? Are they monofilament? Are they multiple filament?
They're hooks.
And just one, or you're deploying many?
You're deploying, actually, the way it goes in, it deploys as a hook. That's how it lifts it up. So you actually will go ahead and put in two.
So 2 hook threads.
Yeah.
Wow.
If you did the monofilament single threads, that's different because you do have to actually position them in a certain direction and technique, as you know, and then you have to put multiple threads and you have to anchor them properly. That's correct. You can also use the, what I call invasive versus non-invasive threads. So the PDOs are more of the non-invasive. The mint threads that you're talking about are more invasive, and they're a surgical approach, and you actually have to do them under a sterile environment as opposed to an aseptic technique. And that's different because you just basically would hook it up and define and lift it with that, as you know.
How long after?
The post is immediate.
Mm-hmm. And how long do you tell them that this results in?
I tell patients that depending on, as we do with fillers and neuromodulators, depends on their activity, their lifestyle, their body's going to break it down. Because if you think about it with threads, what do? They're neocollagenesis. So even with sculpture, it's neocollagenesis. So depending on the person's lifestyle, so I tell them, the literature will tell you anywhere from 1 to 3 years. The realistic expectations for me to set for them is 12 months, which is 1 year. I tell them at that point we can go ahead and reassess. If they need to continue, add to it, build, or maintain, we add more. If not, and we go into 1.5 years, great. Same thing with fillers.
Do you ever restrict activities after this?
Yes, I usually tell them to keep it, stay calm, stay, rested, relaxed for 48 hours, just like I do with the Botox and fillers as well, and no facials. Oh, absolutely. No facials for 2 weeks with any thread procedure. No laser procedures for 4 to 6 weeks. Just because you don't want to disengage the threads, you do not want to break down the threads, or you don't want them to move somewhere else, just like you would not want filler to be displaced.
Do you personally feel like with a thread nose lift, it's less riskier for vascular compromise? Because even with an HA, you can get compression causing necrosis, but
Absolutely. With the PDO threads, what's nice about them is that you have minimal to no vascular occlusion. Now, when I say that, I'm talking about the thread itself is not going to cause vascular occlusion. Now, if you don't know proper technique, proper anatomy, you can cause vascular occlusion, because how do you get it if it's not the product? You get an occlusion crisis by compression. So if you hit a major artery and vessel and you have a hematoma and swelling and you don't, immediately respond to the situation, from compression, you can still get occlusion. So with the nose, you still need to know, for any kind of rhinoplasty approach, is your anatomy. You need to basically make sure you don't hit any major artery or vessel, but the actual product, being the PDO thread, is a non-occlusive type of product. So yes, it's much minimal risk compared to HAs.